Hello everyone. Thank you for joining us today on this webinar on our discussion of a new rotary file system called HyFlex EDM. I want to thank you all for logging in and spending the next 1 hour with us. A little bit about me. Allow me to introduce myself. My name is Sam Alborz. I'm a full-time practicing endodontist in the state of Tennessee, on the east side of the state, a small town called Knoxville. And the name of our practice is Tennessee Microendodontics because we're in the state of Tennessee. And everything we do is essentially through the microscope. So here's a picture of our practice. We try to keep it as peaceful and tranquil as we can. And before we begin with all the rotary instruments and all the technical stuff, I want to tell you a little bit about my hobbies. I enjoy scuba diving. I hope we have some scuba divers out there. And my last trip was a shark dive with the great white sharks, cage diving to be specific, off of the coast of Mexico. There's a small island called Guadalupe Island. And about 6 months out of the year, these great whites show up there and they drop you down in a cage about 40 feet. And you get to enjoy these magnificent animals. And every once in a while, you know, they get a little bit silly, these sharks, and they try to get a little bit close and actually get a little too close. Yes, they try to get in the cage and they get wedged in there and eventually they pull themselves out. But they're magnificent creatures, very powerful and very smart. We're going to begin the discussion with nickel titanium and how it changed the world of endodontics, and it truly did. For decades, folks were doing endodontics through hand instrumentation and gates, Glidden burrs, and things of that nature. And cases were taking a long time. They were a little bit unpredictable. But rotary and nickel titanium files came along and really changed the way things were done. And the HyFlex EDM file, which is this new file system we're going to be talking about, is doing just that to the world of nickel titanium. It is revolutionizing the world of nickel titanium files, and it's completely changed the behavior of these files, and we will touch on exactly how it does that. But going back to nickel titanium files, what they offered us at the time that they came out was a more predictable, more efficient, and more consistent shape. And you all can agree on that. And everybody has their own flavor on what kind of shape they like to achieve when they're performing endodontics. For example, my referrals know when I do a case for them, just based on the presentation of the post-op radiographs that we send them, oh, this must be Sam Alborz's case, and so on and so forth. So the problem with nickel titanium files is that they separate. And even though they make our life very much easier, more efficient, but they do separate. And you've all probably, if you've done enough endo, you have separated files. However, with this new file system that I'm going to talk about, I think we can avoid a lot of these mishaps, yeah, and make the efficiency even more of a factor. So we have a more efficient file, more effective file with far less mishaps. And why do these files fail or separate on us? And it's due to these reasons that I have on the screen primarily. And basically we have cyclic fatigue, static torsional fatigue, and dynamic torsional fatigue, and I will touch on each one of these topics here in just a moment. Cyclic fatigue is you have a file that is going around a curvature inside a canal at 300, 400, 500 RPMs, and there is compression and tension at different points around the curvature, and eventually the file will separate. These are the ones where you can even use a brand new file straight out the pack. You put it in the canal and click, you hear the sound, and you take it out, and it is a gut-wrenching sound. Nobody likes to hear that sound. Whether you're a general practitioner or an endodontist, Nobody likes to hear that sound. And it looks kind of like what you see on the screen here. The file completely separates at a given point. So in an experimental level, if you are spinning this file at 300, 400, 500 RPMs, and this is spinning around this curvature, we do have tension on this side of the file and compression on this side. And if you just take a simple paper clip and bend it back and forth, I don't know, let's say 20 times, 30 times, that paper clip will separate and break on you. And that's essentially what we are doing with these files when we're spinning them in a curved canal around the curvature. So this is called cyclic fatigue. Torsional fatigue is when one end of the file is spinning, for example, that's attached to the motor, and the other end becomes static or is not moving. And usually that's when the file is binding within the canal, or if it got screwed into the canal, you were pushing a little too hard. And what happens with these files when you take them out, a lot of times you'll see this unwinding of the flutes before the separation of the file. That's why every time you use a rotary instrument, you got to take it out of the canal and inspect the flutes after you've cleaned them and make sure there's no unwinding. So the unwinding is essentially a warning sign telling you, hey, I'm going to separate, don't use me anymore. But essentially this file is now no good and it needs to be discarded, because the next time you use it, there's a high likelihood that it will separate. So on the torsional fatigue, as you can see, there are some warning signs to help you. That's assuming that the file has not yet separated. Dynamic torsional fatigue is another reason that we see files fail, and that's really when there's a tremendous amount of friction on the file. A lot of times when you use a too large of a file for the canal, a file that has far too much taper or too large of a tip size, and there's a lot of binding between the file and the canal walls, and that just generates so much friction that the file can separate on you. And again, you'll hear that clicking sound. You'll take the file out and a good portion of the file is missing. And it's a conversation that you do not want to have with the patient at this point as to why this happened and what are we going to do about it. And as you all know, an ounce of prevention is the best thing. If we can prevent these things from happening, you will get to perform efficient and effective endodontics without these mishaps and these conversations that we do not want to have with our patients. Some of the other factors that may lead to or cause file separation are the diameter of the file. Actually, the thicker the file, the higher the likelihood that it may separate and fail. The taper, also larger tapers, for example, a 3506 file has a higher likelihood of separating on you than a 2504, believe it or not. And the degree of curvature. The degree of curvature is something we all know about, but there's one thing I want to point at as far as the degree of curvature. Again, before I move on to that, remember that with torsional fatigue, and this may be at the questions at the end of this lecture that you may need for your credit, torsional fatigue does have some warning signs prior to separation, the unwinding of the flutes, while cyclic fatigue, there are no warning signs, and it's just a clear fracture of the file. Torsional fatigue, warning sign. Cyclic fatigue, no warning sign. Okay. And so the way to avoid a lot of these issues is with these files that we're going to talk about today, which is the HyFlex CM, controlled memory, and the HyFlex EDM, which is stands for electric discharge machining. These files will exhibit a tremendous amount of flexibility. And by doing so, if you push the file beyond its limit, it will tend to unwind on you, particularly the HyFlex CM files. And that is simply a warning that is built into the file that tells you, doctor, please do not put this file into the canal again, because it will separate. And when this happens, unlike the other rotary NiTi, traditional NiTi files that we looked at, If you put these files into the autoclave, the heat generated from the autoclave will allow the file to regain its shape, and the file can be used again in subsequent cases. This, for example, is a controlled memory case that I did. This is actually a third molar, a wisdom tooth, that was used as a pontic for this 4-unit FPD or bridge. There was very limited opening. They had a good bit of curvature and dilaceration to the canals, as you can appreciate. Had a substantial radiolucency. Incidentally, this case was completed by me in 2 visits with calcium hydroxides in the canal between appointments. And you can see that I was able to achieve the shape that I wanted, some apical enlargement, and also maintaining the true canal anatomy without straightening out the canals or transporting any of these portals of exit. This is a classic CM case that we do in our office day in and day out. This is actually called the Cape of Good Hope. It's in South Africa. It was once thought to be the most southern point of Africa, but later they discovered that it wasn't quite the most southern point of Africa. It's a beautiful place. We actually went here to do some cage diving with great white sharks, and we went hiking here, and we met this guy. He is called a rock hyrax, and very friendly guy. He came right up to us, and these are actually, believe it or not, the closest relative of the modern-day elephant. And as far from a DNA standpoint, not from a size or looks. And their upper incisors are very similar to the tusks on an elephant. So there you go, a little bit of trivia for you. Moving on to controlled memory. What is so significant about this controlled memory? It's a form of NiTi file that has a special treatment that has enabled these files to behave in a certain way. In a nutshell, in a very simple form, there is no shape memory at room temperature on these files. What does that mean? That means that, for example, if you were to take the file and put a bend on it or pre-bend the instrument, it will maintain that same shape without recoiling back to its original shape. All NiTi files that are out on the market, once you bend the file, it would immediately recoil back to its original shape. And that recoil makes the file, first of all, more stiff, and also will have a tendency to straighten out the canal and maybe possibly ledge or transport the apex from where the true anatomy was located. So that's a unique thing about these files. So because they are so flexible, they will allow you to track the canal without any issues. They have great fatigue resistance because they are not a stiff file. And if you were to push them beyond their limit, they will unwind on you, give you a warning, and you can put that file back in the autoclave, and the heat generated from the autoclave will allow the file to recoil back to its original shape and allow it further use for subsequent visits. When you have a very flexible file, a file that will not recoil back to its original shape, you can avoid mishaps such as the ones you see on the screen here, which is a ledging, transportation because the file wants to straighten out, or even worse, perforation. All of these typically will lead to failure of your case, inadequate shaping and cleansing of the apical 1/3, and subsequent recurrence of the lesion. A lot of these things can also be avoided with good hand filing and a good glide path. Please remember that regardless of whatever system you use, always make sure that you have a good glide path with your hand files. And a glide path, it means taking a 10, then a 15, and ideally a 20 hand file to length, where these files can easily slide in and out the canal prior to the introduction of any rotary instrument into the canal. A lot of times I see general practitioners getting into trouble because they jumped to the rotary instrumentation too fast, and because the manufacturer told them they can hand file to an 8 or a 10 and get going. Please make sure you spend a little bit of extra time on hand filing, and that will prevent a lot of your problems. The other thing I like about this file system is a variety of tip sizes and tapers. Very few systems out there start at a size 15 on the tip and extend to a size 60, and then offer you a 0.04, 0.06 taper with all these different lengths to choose from. This 0.08 is an orifice opener, and that's why it has a large taper. This is another controlled memory case that was performed in our office by me. This was a case that was attempted by a general practitioner. Not only do we have the obvious mesiobuccal dilaceration, but look at the distal buccal and even the palatal. This is a very difficult case. This is, in my opinion, a case not worth a general practitioner's time. So here we have MB1, MB2 negotiated, control memory files, great shape, maintained true anatomy, did not transport the case, and the patient was very happy. And incidentally, we did a core buildup with paracore, which is also offered by Coltine, with dual cure bond and dual cure buildup material. What we're seeing a lot of today, I was just in San Francisco a couple of months ago meeting with my colleagues at the American Association of Endodontists meeting. And we had endodontists there from around the world, from Brazil, China, Japan, Mexico, El Salvador. And the consensus was that we are seeing a lot of cracked teeth. This is very common here in the United States. I'm sure it's common wherever you're listening. Specifically and especially, we are seeing a lot of cracked teeth among post-endodontically treated teeth. So we're seeing a lot of vertical root fractures and things of that nature. Yes, a lot of that has to do with bruxism and function and parafunctional habits. However, we believe now that a lot of the reason we're seeing these cracked teeth is because of over-enlargement of these canals. Go back to the days where people were doing Gates-Gliddens and hand filing their cases. And look at the shapes, that Coke bottle over-tapered shape that you were seeing. And then we went to a traditional nickel titanium rotary instrument shaping system. And we saw a lot of 0.06, 0.08 large taper shapes. I myself am guilty of that because that's what I was taught, and that was the trend at the time I became an endodontist. But we also see in the previous cases that we've done aggressive Gates-Glidden use. Gates-Gliddens are okay to use. For example, today, in today's modern endodontics, if you want to resort to the use of a Gates-Glidden burr, I would say a size 2 is about as large as you should go. The size 3, 4s, and 5s, I'm afraid I would probably throw away if I were you. Also, large tapers. A lot of people using the 0.08s and things like that. That's called the deep shaping technique, where you like to see a lot of taper in the coronal, 2/3 of the canal. That is aggressive, and that weakens the tooth. There are thin walls of dentin that then expose the tooth upon occlusal loading to cracks and fractures and so on and so forth. And another issue is a large opening for your endodontic access. And there's many other reasons, but these are the primary reasons that I think there's an increase in the number of cracked teeth that we're seeing. So an easy way to avoid a lot of these issues is by the use of a very popular term now called minimally invasive dentistry or minimally invasive endodontics. Again, prevention, prevention, prevention. So here we have, on the right, the traditional access that we were all taught in dental school. They were taught that you have to see every single orifice when you're working, when you're looking down on the canal. On the left is my access. That's a 4 round burr through a porcelain crown. And what I would like to share with you is you only need to see one orifice at a time. If you can move the mirror and only see one orifice at a time, you can accomplish your case. You cannot work on 2, 3, or 4 canals at the same time. So just make it big enough to see each orifice and have straight line access into each canal. Now, I can probably do a root canal for you through a 2-round burr. But I'm going to miss canals. So make it as big as you really reasonably need it to be, but don't over enlarge it. As long as, again, you can see one orifice at a time, you should be good. Before I move on to the actual rotary instrument system that I'm going to talk about, there's one question that I'm always asked by many practitioners wherever I go and I speak. And what about this one file system? What about the single file system? What do you think about that? I'm afraid there's no such thing as a single file system. Root canal anatomy is highly, highly variable. One such prominent system out there is the Wave 1 by Dentsply. And they put the system out there. It's reciprocation. It has many pros and cons, which I don't want to get into. But what I want to point to you is that the Wave 1 folks came out with a new file called the Wave 1 Gold. So they took their original file that they presented as a single file system and made some modifications to it. They have enhanced the flexibility. So they've added some of the stuff that we use in the controlled memory files, right? So they're agreeing that their original file was too stiff. They have extended sizes. Again, rotary instrumentation and canals come in different sizes and shapes. They only had 3 sizes to begin with, so they've added more tip sizes. They have reduced the taper of their files, agreeing that they were too aggressive, coming in line with the minimally invasive dentistry and so on and so forth. And they've tried to increase their cyclic fatigue resistance, agreeing that they used to get separated instruments. The dentist was told that this one file will reach the apex, and they push and push and push and end up with this scenario here, ladies and gentlemen, where the tip of the file will bind and the file will separate. And this is the stuff I get referred in my office to fix. And I'm afraid this was easily avoidable with a good glide path, good hand file, and not pushing the file. If the existing file they were using was not working, whether it was rotation or reciprocation, they should have gone to the next file smaller in size. But however, the manufacturer told them that this one file will go to the apex, and they kept pushing it. So just to recap on the single file systems, remember that do not exist because root canal anatomy is highly variable. They have made modifications. On the left, we have the original Wave 1. On the lower right, we have the new Wave 1 Gold. More flexible, reduced taper, and added more tip sizes. If you are doing a maxillary first molar, you're probably using the primary file, which is what they recommend for the mesiobuccal and distobuccal canals. If the palatal root, which oftentimes is a large canal, has an apex of 40 or 45 to begin with, can you finish with this file? Absolutely not. So you have to go grab the 4505 file to do the palatal. Now you have found the MB2, the mesiobuccal 2 canal. That is a very slender canal. Will this file that you were originally using on the mesiobuccal and distobuccal fit in the MB2? Absolutely not. So you probably have to grab this file. So as you can see, we now have probably used 3 files to accomplish this 1 molar because of the highly variable canal anatomy that we deal with. So there's no such thing as a single file system. Please keep that in mind when you are presented with any rotary system out there. Today we're going to talk about HyFlex EDM. So the HyFlex controlled memory files that I showed you have been out on the market now for a little while. The newest file system to come out is HyFlex EDM, which stands for Electric Discharge Machining. Again, it's a NiTi file that has a special proprietary treatment that enables to be this special file that we're talking about. Again, and just like NiTi files revolutionized rotary endodontics, HyFlex EDM is revolutionizing nickel titanium. rotary instrumentation. This was their ad slogan that they came out with, and I saw this slide and I thought to myself, my goodness, that looks like a movie that I saw once upon a time. Yes, Mission Impossible. I really thought that looked like Mission Impossible. Actually, they asked Tom Cruise to come to the launching of the file, and he showed up. He was gracious enough to show up and for the launching of the file. No, I'm joking. That's an absolute joke. Forgive me for that. But on a serious matter, let's talk a little bit about research about this file. So if you ask any manufacturer right now, what is the most flexible file in the market, they would have told you HyFlex CM. HyFlex control memory files are the most flexible, which is what you see here in the yellow bar. The HyFlex EDM file in lab test studies is twice as resistant to cyclic fatigue as the most flexible file that was already on the market. So we have improvement in cyclic fatigue resistance for sure. Some research for you in the International Endodontic Journal in May of 2015. They tested two files. They compared the HyFlex CM 40.04, which was already the most flexible file on the market, with the HyFlex EDM, which is the newer file, 40.04, same tip size, same taper. And they found that the cyclic fatigue test showed 700% improvement in resistance to fatigue and fracture. So we have a far more flexible file that is far more resistant to fracture than even the most flexible file that was already on the market. Another study here that compared actually the cyclic fatigue resistance of HyFlex EDM and compared it to the actual Wave 1 and Reciproco 25, which is the German version of Wave 1, the single file systems, if you will, the reciprocating files, excuse me, and found it to be far more resistant to cyclic fatigue than those reciprocating files. So the way the manufacturer presents it, this is the actual pack that you would buy. There are 3 files in this, and you do not have to get these packs. You can buy individual files as you need, and I will help you pick those. Orifice opener, they recommend hand filing to a 10 file. I highly recommend a 15 file, please, no matter what system you use. Obtain your working length, and in doing so, do not introduce hypochlorite at this stage. Open your access, find the orifices. Just scout the canal a little bit with a 10 file, open the orifice, use some lubricant on your file, something like Fialese or RC Prep or Glide or what have you, and that will coat your file. Use the apex locator to obtain your working length. That lubricant will help you get a better reading on your apex locator because it prevents a lot of interferences with the walls of the tooth. And then the next file you use once you've obtained your working length and you've hand filed to a 15 is a glide path size 10.05, 10 at the tip. So if you've hand filed to a 15, technically at the very apex of the tooth, the very tip of your working length, this will not bind. And we have a 0.05 file that you take to working length ideally, and if it doesn't want to go for whatever reason, you can stop 1 or 2 millimeters short of your working length. Irrigate, irrigate, irrigate. The next file is what I call the bread and butter file. It's called the HyFlex 1 file. This has a variable taper and a 25 tip. This will typically go to working length in 90% of your canals. If you have hand filed to a 15 and you've gone through your glide path, this guy is going to go to length. It's in a pecking motion, so advance a millimeter, withdraw, advance a millimeter, withdraw. And every time you take it out, please wipe the flutes, inspect the file, and then reinsert the file back into the canal. Always, always make sure that your canal and your chamber is flooded with hypochlorite. And always with this file system, whether it's control memory or EDM, spin the file after you have entered the canal. So what we do is we flood the chamber, we take the file attached to the handpiece, put it inside the canal, meet resistance, withdraw a millimeter, you don't want it engaging, spin the file, and then advance in a pecking motion, back and forth. Never spin these out of the canal and then try to get them into the orifice. They're very flexible files and they're going to move around on you. Once you've taken this 25 variable taper, that means you have a 25 at your apex. You have now these optional files, which in today's world of minimally invasive endodontics are highly recommended for apical enlargement. And they consist, again, of the EDM technology, very flexible files, 40.04, 50.03, 60.02. As we go up in tip size, we reduce the taper of the file. I use these routinely in my practice, and I'm going to share with you some sample cases. The manufacturer also has these guidelines for you. In a straightforward case, whether it's a molar or bicuspid or what have you, you can go orifice opener, hand file 15, glide path, 1 file. If you have a really tough case that's highly calcified and very dilacerated like this molar here, you can do the orifice opener, hand file to a 15, obtain working length, glide path, and just before you go to the 1 file, which is the 25 variable taper, you can take a 2004 control memory file to bridge the gap between this 10.05 and the 25 variable taper. As a clinician, as an endodontist, I have never had to resort to this, just so you know. If this guy does not want to go to working length, we stop short, let's say 2-3 millimeters. I've shaped to here. I will finish with control memory files just to finish the apical 1/3. So orifice opener, 1 file, and if it's not going and it's not advancing, we finish with control memory files. Let's say 2504, 3004, 2504, 3004, 3504, whatever you wish to finish your case to. This is a close-up, an enlarged image of the 1 file. Okay? It has a variable taper. In the first 5 millimeters from D0 to D5, it has a 0.08 taper. And then beyond that point, it goes to an 0.04 taper, keeping in line with the concept of minimally invasive endodontics. They also have a variable cross-section, as you can see, and that gives the file a lot of flexibility and then that resistance to cyclic fatigue and fracture. This is honestly the bread and butter file for me. Today, now that I'm far more comfortable with these files, I tend to even skip the glide path file. You didn't hear this from me. I do the orifice opener, hand file 15, obtain my working length, flood the chamber, and start using this file in the pecking motion until I reach the apex. And again, if it doesn't want to go in the last 2-3 millimeters, I don't push it. Irrigate, achieve patency, and then finish with a 0.04 control memory HyFlex CM file. Do this routinely in these shapes. So I'm an endodontist. Remember, I get very difficult cases in the United States. This is a football player. He plays college football here. Came to us, and he couldn't open much. He had a class 3 skeletal relationship. He had a second molar here with a deep carious lesion approaching the pulp, and obviously complex anatomy, as you can see preoperatively. Look at this first molar here. Thank goodness I didn't have to do root canal on that one. But this, on the mesials, we took a 25 1 file, the variable taper to length. And the distal, I gauged the apex once I took the 1 file down with a hand file, and it was about a size 30, 35. So we took a 40.04 and finished the distal, and here's the case. I want to point out that this right here is the cusp of the upper molar. There was so little space here to do this case, and we actually IV sedated this case to do it, this patient. I had to pre-bend these files, enter the file into the orifice, and spin to be able to achieve this shape. The traditional 21 millimeter NiTi file would not fit in this tooth. I tried it, believe me, I did. I had to grab the EDMs, and they were new for me at that time. I was a little bit scared of using them, but as you can see, they worked like a charm. Often people ask me, how do these EDMs perform in calcified canals if there's a lot of binding? Will they separate or do they unwind? Well, this is a lower incisor on an 88-year-old gentleman that I saw with a good sizable lesion here. This one was asymptomatic. We treated that later. But what I'd like to point out here, that this is the rubber dam. This is the rubber dam clamp. Around the clamp, we put something called cool dam, which is a form of composite resin that you put around the clamp to get a good seal. And this is the file inside the canal. As you can see, when I work under the microscope, yeah, I can move the handpiece out of the way and put a bend on that file and spin it while it's in there, and it will do its job. It will follow the true canal anatomy without any issues. And here's the same file out of the canal, and you can appreciate no unwinding, nothing like that noted. And as you can see, my chamber at all times is flooded with hypochlorite, full strength. So the benefits of HyFlex EDM, they're far more flexible than any traditional NiTi file out there, even more flexible, twice as flexible as the HyFlex CM, control memory file. As the file is so flexible, it puts less stress on the tooth, hence fewer cracked teeth. And it's easy to use in limited opening cases, a patient with a second molar or a third molar, and some of the referrals that we get. You can pre-bend these files, place them into the orifice, spin them, and then allow the file to follow the true canal anatomy. You can do apical enlargement with the finishing files, the 40.04, 50.03, and the 60.02, without sacrificing removal of coronal tooth structure. This is very, very important. And you can reduce the number of files. Again, I told you I use the orifice opener and I go straight to the one file a lot of times. And I don't recommend this for your first trial. Please use the glide path file. But I am reducing the number of files in my armamentarium. It is not, I repeat, a single file system, but I am able to reduce the number of files needed. And also, they're pre-sterilized. Very few files come pre-sterilized, but these truly are pre-sterilized files. And this is a German company, and they do this very, very well, and they give you peace of mind. I see some questions here from folks, which I will answer at the end of the lecture, but one of them is about spinning of the file. What I mean by that is do not activate your rotary motor until the file has entered the canal. That's what I'm trying to say by spinning it. So you put the file into the handpiece, put it into the canal, reach resistance, back away from that 1 millimeter, and then activate the rotation of the motor. And that's what I mean by spinning it. The technique is, again, like I told you, orifice opener, obtain working length, use some lube on your hand file. Once you get your working length, hand file to a 15, glide path file to working length, ideally, then go to the 1 file to working length or to resistance, and finish with control memory or EDM finishers of your choice. Irrigate, 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 and establish patency. Patency is when you take a 10 or 15 hand file and you take it 1 millimeter past the apex. Again, by spinning the file, I mean activating and rotating the file after it has entered the canal. Very, very important. This is a molar. The caries was excavated. The canals were located. The orifice opener was used. We're using some lube, the file ease or RC prep, to coat the file, hook it up to the apex locator, and obtain working length. This way you will not have interferences. Coltine has a wonderful Canal Pro Apex locator that I use exclusively in my office, and it's been fantastic. And the need for taking length films for me has minimized to very, very few radiographs to obtain working length. And again, you place the file into the canal, meet resistance, withdraw a millimeter, and activate your rotary. We're going to go through some cases now. These are bread and butter cases that we do in our office every day, day in and day out. Caries exposure. As you can see, the mesials were kind of slender. These are slimmer canals. So 10 hand file was kind of struggling a little bit. I finished the mesials with the 1 file. That's a 25 variable taper. The distal was a little bit larger. I gauged it at a 30 after I did the 1 file. So I enlarged the distals with a 40.04 finishing file. The speed at which you rotate these files is 400 RPM. The speed at which you rotate these EDM files is 400 RPM. Here's another case. This young man was in full orthodontics, bands and brackets and all that good stuff, but he had a necrotic number 3, first molar, and long roots, nice little curvature in them. We obeyed the curvature on all the roots, as you can see, and we were able to enlarge apically. That's a 50.03 on the palette. I took the 1 file to length, and then I finished with a 30.04 and a 35.04 high flex CM file to get apical enlargement because of the necrotic nature of this case. Here's a beautiful case, a mandibular second molar. Look at the apical enlargement here without sacrificing anything coronally. That's a 50.03 at the distal. And I challenge you to find a rotary system that will allow you apical enlargement like that, other than the Lightspeed system out there, which is a very inefficient system. It's a wonderful concept, but inefficient. And the mesials will finish to a 35.04 control memory file. So I do the 1 file, and then I gauge the apex, which you take a hand file, and take it to working length and see how loose it is. If a 25 is loose, then your apex is larger than that. Then a 30, then a 35. A 35 is kind of getting tight, it's not going to length, then I like to take it 1 size higher than that hand instrument. Here's another case. This is one of the first control memory, high flex EDM cases that I did. This is that same access opening as you can see. I accomplished my 4 canal shaping and cleansing, and that's a good dilaceration that you can see on this case. This young lady came to us. And again, I want to point out that while we took the periapical radiograph, that is the maxillary second molar. There was no room in her mouth to instrument. This case, had I have not had EDM files and control memory files and be able to pre-bend them to insert them into the canal, I would have to have sent this tooth for an extraction. We sedated her with IV sedation. I pre-bend the files to be able to accomplish the shape that I accomplished here. This was a 2-step case with calcium hydroxide within the canal between appointments. This young man came to me. He had lost his second molar. This first molar, they looked like large canals. So, of course, we took the 1 file only and we skipped the glide path file. But I focused on apical enlargement in this case. These are 35.04 finishing files of control memory, high flex CM files, and the distal is a 50.03. A 50 on the distal canal of a lower molar is a wonderful size to be able to shape to, and do it safely and efficiently and effectively. Again, you can purchase these files a la carte. You don't have to buy the Clin Pack where there's 3 files in there. You can just buy 1 files, just buy orifice openers, or just buy 4004s. Whatever works in your hand after you've tested these files is what you need to purchase. This is the case I did last week. It was a calcified case. This lady had lost her second molar because of poor endodontics. Caries was removed. 4 canals were located. This was a tough one. I could barely get a 6 file in this case, 6 hand file. I had to work at 6, 8, 10, 15 hand file and then begin rotary instrumentation. The 1 file did not go all the way. There was some resistance because it was calcified. So we're 2-3 millimeters short. Then I took a 25.04 high flex control memory file and then a 30.04 to finish the buccals. And for the palatal, that was a 40.04 EDM finishing file. Beautiful case, beautiful result. I'm going to answer your questions here in a moment, I promise. This is the unique thing that I discovered about these files. I have a central incisor that's relatively large to begin with. I have a lesion, so I need to control my apical enlargement as much as I can. I opened this case up. It was basically orifice opener, which I could have done without. Obtained working length. 30-35 was loose at the apex. So I took a 60.02 high-flex EDM file, and I pecked and pecked and pecked, and I went to the apex. One file, ladies and gentlemen, one file allowed me to shape to a size 60 with a rotary file, and it shaved my shape. Is this minimally invasive? I think so. My impact on this tooth is not more than the true anatomy that we had to begin with. And we always seal our cases with composite or glass ionomer, and that's a spacer for the general dentist to restore the tooth later. Here it is, just with the file and the tooth right next to each other, 60.02 straight up in a pecking motion. It took a few attempts, but we got there. One file. Here's another central that I did a week after that. Same thing. I don't think I even used an orifice opener on this, to be honest with you. 60.02 to length, and we were done. Here's that same 60.02 file. I want to show you. This is something I took with my microscope in my office, and I put a bend on it. I can probably bend this file even more, and it will not break. That is a special proprietary property that these files have as a result of the treatment that they were given. Here it is in action. So I can even move the file out of the way if I need to see past it in the under the microscope. And this is the actual case that we were doing, is a partially erupted lateral incisor, and gingivectomy was performed, endodontics, and the access was sealed. So again, we said that in order to avoid these cracks that we're seeing so much of lately, and I'm sure in your respective countries it's the same thing, we need to practice minimally invasive endodontics, yes? We need to reduce the taper. We need to reduce the use of Gates Gliddens. We need to reduce the size of our access cavity, and so on and so forth. So what's minimally invasive? We keep talking about this. This is from my mentor. This is not my case. One of my mentors at the University of Texas, San Antonio, where I was trained in dental school, Dr. Rick Schwartz, and he's a strong proponent of minimally invasive endodontics. These are probably 2004, 1502 shapes, and the lesion healed. Look at his access. Look at his impact on this crown. Minimal. It is controversial. There's no solid research out there. With the ideal shapes in the literature, still a lot of 3006s being talked about. We need to enlarge to a 3006. Some studies will show that, okay, as long as we can get the irrigating needle to within 1 or 2 millimeters of the working length, we should be good. A 30 gauge irrigation needle, which is a side port, close-ended needle, right now is the smallest we have, which is about 0.33 millimeters. And I'm sorry, the 25 hand file is about 0.33 millimeters at D0, the apex, and the 30 gauge needle is about 0.31 millimeters. So if you can enlarge to about a size 25, you should be able to get that irrigation needle down there. And other studies say that, okay, you only need to enlarge 3 sizes larger than the first binding apical file, first apically binding file. So if you open the orifice and you gauge the canal with a 10 file, if your 10 file is not going, okay, so that means we need to enlarge it to a 15, 20, 25, 3 sizes up from that. If a 6 file is barely going down, you enlarge 8, 10, 15, and that's where you stop. That's just another school of thought. Here's a wonderful study that compared the smear layer removal and cleanliness of the canal, comparing a 3506, just very aggressive, very high taper, with that of a 2504, and they were the same. So if you can achieve cleanliness with a smaller, less tapered file, why do you want to kill the tooth with a 0.06 and a large tip size? Keep that in mind. What is minimally invasive? Is this minimally invasive where they took the tooth out? A tooth that could have been saved easily with the armamentarium that we have at our disposal, and caused the food trap to be created, and, you know, a tooth that needs a root canal now or possibly needs to be extracted here? No, I don't think that's minimally invasive. This is minimally invasive, folks. Pulp regeneration, which is what we're doing now in the United States. Taking a necrotic immature tooth and revitalizing the pulp, allowing full growth of this tooth to length and width and resistance to fracture. This is minimally invasive. When I look in the future of my crystal ball, it's smaller taper, it's higher volume of irrigants, it's higher concentration of irrigants, and remember, smaller taper, and you can enlarge the tip size. So instead of a 35 or a 3006, finish with a 25 or a 3004. Use acoustic streaming. All of these help us in achieving minimally invasive endodontics. With that being said, I'm going to answer these questions as fast as I can. All right, so bear with me. I want to answer everybody's question. For the 60.02, what type of master cone would you use? Very good question. I use greater taper and gutta percha cones, and typically these days I'm using more .04 cones. So yeah, with a 60 that's tough. You can probably on a 60.02 grab a 25.06 gutta percha cone, cut the tip, let's say 2-3 millimeters of it off, and put it in the canal and check for tug back, make sure you're working length, obtain a working length film to see the fit of the gutta percha cone. I'm not sure if they sell size 60 gutta percha cones. I think you have to take the greater taper ones and cut the tip. Next question. Okay, so people are asking that if you pre-bend the file and you put it in the canal and spin it, will it break? Absolutely not. It will not break. And remember, you are engaging the canal. Once you meet resistance, withdraw, and then you rotate the file, and you will see that it will follow the true canal anatomy as long as you had good glide path with your hand files. Next question. It says, how can you attempt a calcified canal when the first file would not go down? If you have a 15 hand file, circumferential filing, that's filing all the walls of the canal in a circular motion, the glide path file, which is the 10.05, will go down. It will go down to very close to working length, if not to resistance. I hope I answered that question. Next question. This is not related to this, but I'll answer real quick. When the gutta percha goes through the apex, basically they fitted a cone that was long. Does this cause an issue with the future of the tooth's lifetime? First of all, that means you over-enlarged the apex. You've basically perforated and torn that apex, and you did not control your length very well. So that should not be happening. Second of all, when you fit your gutta percha cone and you check for tug back, always obtain a working, a cone shot, we call it. So a radiograph to check the fit of your cone. If you are long, once you fitted that cone before you've completed the case, cut the tip and adjust and make sure you are comfortable with the fit of the gutta percha. Let's see, there were other questions here that I need to get to. What irrigation technique do I use and what concentration? Irrigation is full strength hypochlorite. I have another irrigation lecture that is on this website that you guys can go to if you have nothing better to do. Right now Copa de America is on and the UEFA Cup, so I'm sure you're watching some football. But I use full strength hypochlorite. I remove the smear layer with EDTA, and I finish with chlorhexidine, 2% chlorhexidine. I use acoustic streaming between every single one of my irrigants. Please go to my webinar and listen to it. What speed and torque? I spin at 400 RPMs. Torque for me, I turn it up. I'm an endodontist, so you'll see what you're comfortable with. Are these single time use per patient? Excellent question. On the box of every one of these nickel titanium rotary files that any manufacturer sells says single use. I'm an endodontist. I'm in the United States. We use them more than once. We don't use them that many times, maybe 2 or 3 times. We throw them away. But that is up to you. In other countries where your reimbursement is very low and these files are expensive, people use them multiple times. But that is your choice. Next question. How many canals do you use per file? I do the entire case with the file. I don't change files. So the same one file will go on the mesiobuccal, mesiolingual, distobuccal, distolingual until the case is completed. Oh, I got another. Great job. Very good. Thank you very much. I thought it was a question. What about cases of retreatment? Excellent question. Can you use these for retreatment? Absolutely. If you're going to use them for retreatments, use something to soften the gutta percha, chloroform, or what have you, and then use the one file only. Do not use the glide path file to attempt to retreat at all because it's not sturdy enough. It's a very, very slender file. Variable taper, someone has a question. Yeah, variable taper means at the apical 5 millimeters, it's a 0.08 taper, and past that it becomes 0.04. So that's a variable taper file. With a small access like the one you depicted earlier, don't you risk leaving some tissue behind and creating unsupported enamel? Excellent question, excellent point. The answer is no. I am able to remove all the tissue from my case. I can use ultrasonics. I can use a round, small burr and go under the pulp horns. And remember, my chamber is flooded at all times. And when you de-roof the pulp chamber, everything is removed. We just don't want to over-enlarge the access cavity. And as far as unsupported enamel, the less dentin and the less enamel we remove, the higher the strength of the tooth. We need to stop removing unnecessary tooth structure and prevent these teeth from failing on us. It works with a microscope very well. The question is, does this work under a microscope? As you saw, all my cases are done under a microscope. So what is ideal taper? I showed you the studies. I tend to finish with an 0.04. I finish with a 0.04, and I try to take the one file to resistance or to working length. What's the ideal taper? Folks, look at your pre-op radiograph. If you're dealing with a slender canal like a lower central incisor, don't use a 0.06 or a large tapered file. If you're dealing with a maxillary central incisor, you can use a larger file. Always look at your pre-op radiograph to dictate finishing files. So after a 20.02 hand file, what do I do next? That's what the question is. I use the glide path file, or I go straight to the 25.1 file. That's what I do. Next question is, do you have the data for it fracturing less? Yes, I showed you those two studies. I have many other studies. I just didn't want to bore you. That when a file is highly resistant to cyclic fatigue, thereby you are reducing the probability of it fracturing on you. The next question is, how do you access with a large MOD amalgam already present? In those large MOD amalgams, these days I remove the entire restoration because I want to make sure the tooth is not cracked underneath it. I am not weakening it because I'm simply removing a restoration that was there, and later probably it will get a full cuspal coverage. For joint canals in the lower molar, MBML, I'm not understanding the question. Next question. Acoustic streaming equals ultrasound. Yes, kind of, sort of, yes. It's the activation of the solution via ultrasonic energy. Again, it's in my irrigation lecture. Highly recommended that you do that today. Do I use warm vertical gutta percha? Yes, I use warm vertical compaction of gutta percha to obturate my cases. I'm sorry, I'm going through as fast as I can. How many times can you reuse the file? We talked about that. What is the life of the HyFlex EDM? How many average uses? It's up to you. We use them 2 or 3 times in our office. Twice is really ideal. After you hit resistance with a variable taper with the one file, what do? If it's 2 or 3 millimeters short of the working length, I can grab a HyFlex CM control memory file and finish there. For example, a 2504, and then enlarge to a 3004. So I'm only enlarging the apex. What is the cutting efficiency once you use them once? Sorry, folks, I'm out of time. Thank you so much. I appreciate you all, and thank you and good night.